Thank you. Just to clarify, Commissioner Sanchez, who will be speaking shortly after me, is the Commissioner for OASIS. So they are actually responsible for the setting up the treatment centers, et cetera, for the opioid. But we work closely, OMH, with OASIS for our patients who kind of overlap between the two systems. So we're well aware of the problems with the opioid epidemic. It affects those who have mental illness as well. The K2 affects those who have mental illness. We work very closely with OASIS, but I'm sure Commissioner Sanchez can answer more about what the plans are for the development of the residential, of the kinds of clinical programs. On these PTSD research, I'm not extremely familiar, but I do know of what's happening, and I'd be very glad to speak with them and look at what they're doing. You know, getting evidence-based research out there in so many fields is so important. In mental health now, we often have the skills and the ability to really be able to test and know that something's effective. So we would be glad to understand and learn more about it, for sure. Thank you.
Thank you, Commissioner.
Thank you.
Thank you, Senator. Assemblyman Weprin.
Thank you, Mr. Chairman. Welcome, Commissioner, and I want to thank you in a previous lifetime for all the work you've done in the area of cancer and working with, in particular, the Queens Hospital Center, which, as you know, is in my district and it does marvelous work with the New York City Health and Hospital Corporation. I also, as you probably know, have Creedmoor in my district as well. And I know I've written to you on a few occasions as to some of the complaints now, even with some of the downsizing and transfer of beds, with certain patients loitering in the street and you know, being a nuisance, etc., particularly on Winchester Boulevard, Hillside Avenue, and Union Turnpike, surrounding, you know, the Creedmoor campus. What is the status of security, you know, there, and what are the, I know you're transferring a number of beds. What is the status of the beds now, and what's anticipated as far as transferring some of the beds, etc.? Do you have a plan, and is there a timetable as far as how many patients you'll have at any given time?
Yeah, thank you. At this point in time, Creedmoor has a census of about 320 patients, and at this point we're not really planning to either move patients out of Creedmoor or increase that census. We're really planning on holding that census the same for Creedmoor. On the campus, there are another probably a couple of hundred individuals who are in our residential programs on the campus, which are not often run by OMH, but are contracted with a number of community-based providers. And those individuals are not in the hospital, but live on the campus. We're well aware of the community. It's a wonderful community. We want to be good neighbors involved with the community, and I think we have been talking extensively both with those residences that are on the campus, which sometimes are also individuals who perhaps stand too long on street corners, or to help get them into the programming that they need to be in to ensure that they're getting the services they need, which is important, and also for the community perspective. So we're working very hard with that. We're hoping that that will get better. We have also increased, as I said earlier, the security around Creedmoor. There had been some issues there with the fencing at Creedmoor and with security in terms of individuals coming into the inpatient service. So it really is a combined effort of us working with the community-based providers who are on our campus, and we have regular meetings with the community we've set up, which we're going to have ongoing, to talk about these issues and try to be effective, good neighbors. You know, it's so important that we are able to house individuals with mental illness. That community has been good to us in terms of accepting much of the housing in that area, and we want to continue to have an even better relationship. So we are working on it. Some of our patients sometimes do perhaps loiter a little too long in the neighborhood, but we're working very closely with them for their programming to make sure that they get the services they need, because we ultimately want them to get jobs and move out of residential places and be really vibrant members of the community.
Yes, thank you. I appreciate that. On the Creedmoor topic, as you know, there have been many discussions, I think being led by the Empire State Development Corporation, but in conjunction with the city, as to developing the Creedmoor property that's currently not being used, and there are quite a few acres, and there's a development proposal that's been going on for a couple of years already, involving potential retail, potential housing. Can you give me an update on timetable, what's happening with that development, and what the status is?
I think we have to get to the Empire State Development Corporation. We really are not, as the Office of Mental Health, involved in what happens once the land is released for development. And I think that I know that there are ongoing discussions, but I'm not really aware of the timetable. I think Empire State Development is really kind of takes care of that. Our concern is just that whatever becomes there is good for the community and good for Creedmoor and the other residential services we have on the campus. But we don't do the timetable for the development.
Yeah, I know there was a lot of activity a year ago, and then it kind of seems to have died down. We haven't had any meetings that I know of recently, so.
But I will definitely ask them to get back to you, Senator, and give you the status of where the redevelopment is.
Okay, thank you, Commissioner. Thank you, Mr. Chairman.
Thank you. We've been joined by Senator Phil Boyle, and our next speaker is Senator Diane Savino.
Thank you, Senator Young. Good morning, Dr. Lavelle. I want to follow up on a point that was raised by Senator Ort and another point that was raised by Assemblyman Aubrey, so I'll try and be brief because I know a lot of people want to speak. With respect to the O'Toole settlement in the adult homes, has there been any analysis or tracking of the number of people that have been moved out of adult homes and into either supportive housing or independent living?
Yes, as of this year, there are 200, in the past year, 207 individuals have moved from adult homes into independent living. 3,000 from adult homes have been screened. About 1,300 have said they want to leave. And of that 1,300, 207 have been moved into adult home, into apartments. And we're working to increase that with the Department of Health, to increase that movement even faster. I think we have now gotten into the process better, but we also want to be very careful that when individuals move, they are where they want to be, and that it's successful. And so far we've been successful, so we want to keep that track record. But 207 have moved this year from adult homes into permanent housing.
And with respect to those who remain behind and the adult home operators, many of them have expressed some concern about the fact that there has not been an SSI increase, which helps them provide, the services necessary for those who are going to remain in the adult homes. Is there any consideration to raising the SSI rate?
Actually, the rate for what the adult home, that's DOH. DOH is responsible for the adult home, so I'm not sure. I'm just saying I'm not sure, so I can't answer. Yeah.
On Assemblyman Aubrey's concern about this voluntary restoration to competency at the local level, one of the big concerns that exists at places like Rikers Island and some of the other jails is that you have a large number of mentally ill inmates now, and you have staff that are completely incapable of dealing with them. Corrections officers are not mental health professionals. So my concern, if we move to this voluntary restoration to competency at the local level, is that there must be an investment by OMH to provide professionals to help make this restoration to competency at the local level. If not, I would be very concerned about both the staff and the inmates who would be attempting to be restored to mental competency at the local level.
Yes, this would have to be in special units at the local level with the staffing, the appropriate level of clinical staffing to make sure that it would still, with that included in the cost, would still be a savings, at least as far as we can tell, significant savings to the counties. So what's built into the cost of the jail restoration is that clinical staffing to be able to really provide. And it would be and again, it's going to depend on the county whether they either had the space to do this or are interested in doing it. But if they did have the space and were interested, they could now do it with the appropriate clinical staffing, which we would look at and make sure was the evidence-based practice. This has been done in other states, so we have a track record of knowing the kinds of clinical staffing that would need to be there.
All right, and finally, in the last 2 minutes, one of the big problems that the city of New York is facing, and in fact all around the state, is the rise of homelessness. Now, there's always been problems with people who are under domicile, or they're suffering from income inequality, or they're paying too much money in rent. But we have a core problem that's always existed, and that is the chronically homeless who tend to live in the streets. Many of them are mentally ill. So I'm questioning the need to close mental health beds when we're trying to get people off the street into appropriate service, because these are less likely to be engaged in community-based services. First, we have to stabilize them. So if we're closing mental health beds, how will that help us achieve the goal of providing direct assistance to the chronically homeless who are really suffering from mental illness and need to have that issue dealt with before we can stabilize them in secure housing?
Yeah, it's interesting. There's been a lot of new work done with the chronically homeless, mentally ill, the individuals that you see, kind of on street corners, etc. Housing First is a very interesting evidence-based practice where you really work to get the housing for these individuals and then engage them in the services that they need. I used to work with Project Help in the city, which worked out with the homeless, and it's a matter of gaining their trust, their believing that you're really there to help them. They can sometimes be resistant to services, but when you kind of offer them a really very quickly good housing, they have a very high success rate in keeping people off the streets. So there are other ways to do it besides putting people in institutional beds. And they are more successful in retaining people in housing than putting them in a hospital and then trying to move them quickly into some housing. So you have to have both things going on. When an individual truly needs hospitalization, they should be in a hospital. But there are other individuals who don't really need acute hospitalization. They need stable services in the community, a stable place to live, and the kinds of intensive wraparound services which are not our traditional services. And when those are there for individuals, intensive wraparound services, you can get individuals, and housing, you can get them off the streets. But it does take time. It's not a quick...
I would just say, while that sounds wonderful, I do think, though, the problem you have is engaging people on the street corner, and outreach workers are not going to be able to do that as quickly as if you had a person in a safe environment where their mental health issues and their medical needs, and many of them, as you know, are self-medicating to deal with some of the terrors of the mental illness that they suffer. So I don't think it's as simple as just inviting them in and giving them a secure place. I think we need to have that initial interaction or intervention with that person, stabilize them medically and mentally, and then begin the rest of this process that you raised.
I think it's individual. I think for some what you said is appropriate, but I think for others it can be done in another way.
Thank you.
Thank you.
Assemblyman Crouch.
Yes, good morning, Commissioner. Thank you.
Good morning.
Could you, let me back up here. As I talk to my school superintendents across the district, one of the things that they've brought to my attention in the last 3 years now, specifically outside of the funding for the GEA, and that's not here, but the need for more mental health services in the schools. Do you have programs that are currently there that they could draw from, or are you developing programs? I think it's important that we address this situation, because as we have young people that are bullied, they're coming from dysfunctional families, physical abuse, sexual abuse, and we bring them into school and we expect them to learn, and now we're going to grade the teacher on whether or not that we've successfully taught that person, but there's other underlying issues. And I think this is something that we have to look at and try to address the mental health need for our young children. Can you respond to that, please?
Yes, we do have we have certainly, perhaps not enough, but we do have mental health clinics across the state, about 300, and I think it's about 370 mental health clinics in schools across the state, mental health services, and those do provide really very valuable services in-house in the schools. We also do trainings for school personnel on recognizing problems and issues. We've gone into schools who've asked us to do that, and we've offered to do that for schools, and then help them develop and connect with the services in the community. There's something called promise zones, which are in certain environments. We have one in Buffalo, Syracuse, and 3 other places in the state, which have been very promising because they include getting the schools up to par with understanding what mental health issues are and being able to refer, then working with communication with community-based agencies so they can be available to the schools, and then also having within the school a team that is an ongoing mental health team. So there are models out there. We have them in some of the schools. Quite honestly, we don't have them in as many probably as are needed, but we do have those models, and we will be working over time to expand those throughout the school system. It's a very important issue.
Is it in your budget to expand those?
Not this year, no.
Okay. All right. Speaking specifically about the southern tier, there was an effort a couple of years ago to close the Greater Binghamton Health Center, and we were able to speak with the governor's office and negotiate 90 beds down to 60, with a promise that they were going to be developing more community-based services. Because, prove to us that these beds are now obsolete, they're empty. And I said, you've got the cart before the horse here, because you need to show us you've got empty beds that we can close down, when in fact I keep hearing that it's not enough beds, not enough beds. What community-based services have been established in the southern tier at this point in time?
We have invested in community housing, and we've invested in crisis intervention teams, and we have invested in home-based crisis waivers for kids. So basically, I think it comes to about $500,000 that we've invested in the southern tier. In particular, the crisis intervention teams have helped divert admissions. And I'm sorry, I don't know the exact number of beds we put up, but I know we put up a considerable number of supported housing as well out of real investment dollars. And I think in time, hopefully, that will also help us with the bed census on the southern tier.
Are you seeing any empty beds typically at this point in time at the Greater Binghamton Health Center?
Slowly, a few, but not a lot, because we want to make sure that these services are pretty much up and running before, as I say, before we lower those beds for the 90 days.
We still have a little ways to go then.
Yeah, and the children's,
okay.
We have not lowered any children's beds.
In regard to the jail-based services, I think I know the answer to this, but if we have a state prisoner that's put out on parole, if he's got some mental issues and violates parole for one reason or another, he ends up back at the county jail. Isn't it the county's cost at that point in time to provide mental health services for that individual? Or is it, would the state step up and cover that cost?
I believe it's the county. I believe, I'm not, but I believe that's the county's cost. I think when it comes to restoration, as I was talking about before, the state is sharing some of that when those individuals are transferred to us, but it's the county cost, I believe, that pays for the mental health services. And now we do give some state aid to some counties who have set up some services out of that state aid, but that is up to the county with the state aid that we give them. But I do know that some of the counties have used the mental health state aid to provide some services in the jails.
Talking to a couple of my local sheriffs, they've estimated between 30 and 35% of the jail population is in need of mental health services. So, and I know some of them are state prisoners that violated parole, and now that's the county's got the entire cost of housing and mental health services. So I'd ask that you look at that as a way. I'm very sensitive about pushing the cost down to the counties from the state. I came from county government, and I think we need to be very much aware of where the costs are really being paid.
Yes, and I thank you, and also I know we're trying to work on the CIT, the crisis intervention training and diversion, because what we would like to do is also help the counties with that to avoid people even getting into the jails. And with our crisis intervention teams, we're hopeful that will also help divert out of the jails. But we will look into that. Thank you.
Thank you.
Thank you. Our next speaker is Senator Tim Kennedy.
Thank you, Commissioner, and thank you for your responsiveness when we have reached out to your office. Some of our colleagues have already brought this topic up. It's the Western New York Children's Psych Center consolidation. You've made it clear that the state continues to move forward with the plan to consolidate the Children's Psych Center at the adult facility. It's extremely concerning. We've talked about this numerous times. I know you've been out in the district to see the facility. There are thousands of individuals that have been positively impacted by the Children's Psych Center that are really galvanized in opposition behind this. And it baffles me that the state continues to drive this agenda forward. I think it's counterproductive, and I truly think that we need to take another look at it. That being said, has the state explored any other ways to achieve the savings that, I had heard at $4 million? I know you mentioned the number $3.5 million earlier in your testimony to save that money without this consolidation.
I think the purpose of this is to really spend, I think, our healthcare dollars in a way that is really serving the community best. And I realize that, in fact, I'm very pleased that the community feels as positively about the services we've provided in Western Children's. But we are truly going to be providing the same level of quality. We will be providing the same number of beds, the same staff, the same good service on the Buffalo campus. And I think this is what transformation in healthcare is all about. How do you spend your dollars wisely? How do you make sure that we're really converting what are dollars that sit in institutions into community-based? So that's why we're doing it.
So anytime there's a consolidation of services, the question, to save money, the question is also at what expense? And the question that continues to come up is whether or not the expense is to our children in the community, those individuals that we know go to the Western New York Children's Psych Center, we know have a very positive impact. There are very positive outcomes that come out of there. The old saying, if it's not broke, don't fix it. Mm-hmm. That continues to come forward. It is an enormous amount of pushback, and I'm deeply concerned that the question in mind here is whether or not this consolidation is going to impact our children negatively. And I will stand opposed, and I know my colleagues from the Western New York region are opposed to this consolidation if, in fact, the expense is going to be to our children and their futures. And, it's very concerning.
Yeah, thank you. But I truly think that this is something that offers an opportunity for our children and families. I know we're disagreeing, but I'm saying basically that there will be almost 1,000 more families served. We are serving 500 more families now with the pre-investment, with another $1.5 million going into the community, another 500 families. These families are not getting services now. We'll have the opportunity to provide it. And we will be providing the same, I believe, and I know that this is where we're disagreeing, the same high quality of care on the Buffalo campus. I do not think that at all that we will be shortchanging the children in Western New York.
So can you speak to the services that would be provided with this savings and how those services will be provided?
Yeah, what we have so far, we have put up about 24 home-based crisis waivers, which provides community-based services. We have a mobile integration team that we have put up, which is working with families at home in community-based services, crisis intervention services. We've added clinic slots in Western New York, in the Amherst Clinic and in some other clinics in Western New York. We've put workers in 2 schools in Western New York. And when we add the additional savings, which would be another $1.5 million, we will be setting up crisis respite beds for children, another mobile intervention team, and additional clinic slots. So this is really going to serve, I think, when we're finished, anywhere from 800 to 1,000 additional children and families in Western New York. And I just think that's really good for the community, and we'll be serving those families. At the same time, this high-quality care that we are providing, the same clinicians will be at Buffalo. Buffalo is being redesigned to be extremely child-friendly, to provide high-quality care. We've had excellent architects. We've worked very closely with the community on their suggestions about what it should look like, how the space should be redesigned. We will continue to work with them, and I would hope that if this happens and this move occurs, that a year after they're there, we will have families who will come forward and say, my child's getting excellent care on this campus.
Are there other state facilities or standalone facilities? Are there other locations that the state has looked at other than this consolidation on the adult campus for the Children's Psych Center?
Well, this is the way it would serve to be able to actually save the dollars. I mean, I think that other options would probably, if we were to just move it to another space, it would cost the same amount as it's costing now.
Is that something that you would explore?
I think at this point we are really hoping to be able to move forward with the Buffalo plan.
I would urge you to consider other locations.
Thank you.
Thank you.
Thank you. Assemblywoman Jaffe?
Do you, is it working? Yes, okay, thank you. Thank you, Commissioner. Appreciate the opportunity to have this conversation. I know that there have been significant downsizing in the last last few years. We've closed about 449 beds, and the proposal now is for another 100 beds. I represent Rockland County, areas in Rockland County, and I've been hearing from local community organizations and so many involved in the community, a real concern about how we are moving forward in responding to the availability of mental health services for our children. There are concerns about staffing, concerns about psychiatric support, concerns about even the transportation for these youth who are now being transferred to local sites. So what is in place and what is being provided as we move forward to assure that we have the sufficient staffing and psychiatric services and everything that really is needed that can be provided to our children and our youth that are being transferred from the psychiatric sites to local homes, houses, local areas?
The support services that we're putting in place are really very much home-based and community-based. So it includes things like home-based crisis waiver services, home-based crisis intervention services, where workers go in and work with families in the home as opposed to just having, although clinic services can certainly be effective, just having individuals and families come to the clinic. So the dollars that we are investing in the community are really services that bring the services to the home. And the new Medicaid expansion, which is going to happen as of 2017, is really exciting in this area because it's going to really provide through Medicaid dollars to do home-based work, peer advocacy work, family advocacy work, and really move the services to the families. That doesn't mean we won't still have clinic services, but those in-home services, evidence-based services, have been shown to be so much more effective with families that are in distress, and especially if you're working with seriously emotionally disturbed children. So the movement into children's managed care, the $30 million that is going to be there to expand those, literally expand those services across the state, I think will definitely help. I also think that there's an issue with psychiatrists, for sure. One of the things that we have done in the state is we have something called Project Teach, where we have telepsychiatry with child psychiatrists who are available to consult with clinics or pediatricians or others through telemedicine. We've been quite successful with using that, and we're going to be expanding that so that we can really reach out even to more communities, because I think the shortage of child psychiatrists is not going to go away quickly, and it's very important that we use whatever, including technology, is in our armamentarium to be able to work with it. And then in our psych centers, in the budget, we are having a loan forgiveness program to be able to try to recruit more physicians who have just graduated into our system by helping to pay off their student loans through the New York loan forgiveness program. So we're making efforts to expand child psychiatry availability across the state, but it's difficult. It's a national shortage at this point.
The concern also that these residential sites, whether there is sufficient staffing in place and an ability to be able to connect to community and then also provide the services that we were just discussing in terms of psychiatric assistance, even jobs for those who are older youth, and the ability to be able to have the transportation from that residential site to the job, for assistance and a variety of entities. So those are the very real concerns, and it's being suggested that very honestly, it's not being provided. Yeah. And there is a challenge, clearly, with assuring that is something that is in place.
Yeah, and we're hopeful that with some of the transportation issues can be helped by some of the dollars that are available in both the HARP program and managed care, but we have to work on that. The changes in the rules about transportation have had a significant impact. Federal rules on transportation reimbursement for Medicaid have had an impact, and I think we are still working to figure out how to best get those dollars, because transportation is an absolutely critical part. If you can't get there, you're not going to get the service. So we are working with that, and in some places we've used state aid to actually provide that transportation, but we're working very hard on that issue. It's
Thank you very
important.
much. Thank you very much, Commissioner.
Thank you, Senator.
Thank you. Our next speaker is Senator Gustavo Rivera.
Thank you, Madam Chairwoman. Good morning, Commissioner. I want to focus on something we haven't spoken about yet. It is Part L of the budget as it relates to the to temporary operators, and the fact that it seems that both for your agency as well as OPWDD that there's a change in the way that the process works. So, in particular, I just want to know how currently the process works. If there is an agency that either through malfeasance or through inept management or what have you, still serves a population that has high needs, but needs to be taken over. What is the process currently, the changes that are proposed here, and what is the necessity of changing the process to what is in Part L of the budget proposal?
Yeah, the current process is that we can learn about issues by reviewing the financial plans, which we get every year from agencies, and usually it's a financial issue with an agency. Sometimes it's a clinical issue, but most often it's a financial issue. So in those reviews, we work with agencies. Other times agencies come to us even in the middle of the year or before those reports just saying they're having difficulties. Once they come with us, we have a large amount of technical assistance that we work with them to try to help them become solvent, to help them be able to deal with the problems that they're facing. We work with consultants if we have to. We work with our financial individuals. We have sometimes helped them do consolidations, mergers, technical assistance on how to redesign. So that's all in place at the current time. What the temporary operator does is give you a little bit faster way to move in and assist if you have to. We don't expect we would use it very often, but every now and then an agency gets into trouble fairly quickly, and we need to be able to move in to make sure that we can assign a temporary operator that can then take over the main operations of what's happening while still trying to get the agency back on its feet. Our main concern through all this is always to make sure that the services are provided appropriately to the individuals who are being seen by the agency, and to make sure that their care is safe and make sure that they get the care that they need. So this would just be another tool in the armamentarium. I think that we have lived through a few major issues. One was with FEGS last year, and there might be times when this would be useful. Other times we would continue to use the current way that we work with agencies.
And so, and by the way, FEGS they're obviously in the city. They were in the city of New York. They were right in the 5th floor and the 4th floor of the office at in my office building. So I was, a lot of the folks there lost their jobs, etc. I was kind of witness to it firsthand. But my question really is the current process requires this, because this would expand, if I'm not mistaken, it would expand the authority of the agency to assign a temporary operator. Yes. Without the involvement of a court proceeding. That's what
yes.
So it would kind of sidestep that. And so so on the face of it, the need would be so that it be done more efficiently and more effectively. I
yes,
guess.
Yes.
Ultimately, the decision would be made by you and your staff about if this is approved and you get the authority to do this, then the trigger would be. I mean, there's obviously a lot of definitions here about extraordinary financial assistance,
right.
Serious financial instability, etc. Outside of that, the details as far as what would trigger your decision to take over an agency would be really done by your staff. It would be internal.
Yes.
And currently that you do not have that authority.
No, we do not.
Okay. I might come back later for more questions, but I wanted to clarify that that's what
yes.
was here. Thank you so much, Commissioner.
Thank you.